beds and the medicines and the security for health personnel and so on, and not to forget the rehab part. So there are some guidance and there are some documents available to identify such resources in general. So my point here is trauma center is not necessarily a concept for high income or a developed country, but it can be implemented even in a low and middle income setting given our resources and our systems and our capabilities. So to conclude, I just want to highlight that trauma center accreditation is an important step in improving the outcomes and saving lives. There is a strong evidence to support the implementation, which I shared with you, the Canadian experience. The trauma center's parameters can be defined nationally, provincially, without necessarily copying the available standards in high-income countries. We can do it on our own. It is certainly not a resource-intensive or capital-intensive program. It will increase the focus on training, registry, organization, planning, and I think JP and Apex Trauma Center is a classic example in this country, which has now grown to a center of national excellence and international excellence in this regard. Just creating a focus will invite activities and excellence in its own way. And finally, I want to conclude by saying that we all should agree and consider that it is high time for countries in our region to develop and implement our own trauma center standard for the benefit of patients who get injured in our countries. Thank you for your time and attention.
Thank you very much, Dr. Joshipura. There's time for a couple of questions for Dr. Joshipura before we move to lunch.
Yeah, that's an important question. I think the question is who should accredit the hospital. I think in high-income countries we have a professional body such as the American College of Surgeons, right, who would go and inspect the body. I think in our part of the country such institutions are very weak. So I think there are two options. One is that we can ask the current accreditation bodies like NABH, National Accreditation Board for the Hospital, that can take up as one of its activity number one. Or we can make a plea to the Ministry of Health with all the stakeholders, and with the help of JP and Apex Trauma Center, we can get the Ministry of Health in India to come out with a trauma center accreditation body. I think that there are several options, but there is no, as I told you, there is no one prescription which will work here. Thank you for your question.
Don't you think that only accreditation and defining the trauma center would not suffice in our country, particularly with the prevailing mesh in traffic and roads and other security measures?
Yes, I certainly agree to what you're saying. But clearly, as this group, as a health professional, this is what we can do, right? Because traffic is not in our hands. The vehicle safety, the engineering part is not in our hand. Enforcement is not our hand. The policing is certainly not in our hand. The licensing is not our hand. We cannot put helmets on every head. Drink driving we cannot check. We cannot go and check that every person has a seat belt put on. So what we can do as a healthcare professional is post-crash care. That is the best that we can do. This is what we have competency to do. And I think this is what we can contribute. The rest of the pillars, I guess, the rest of the pieces of puzzle, we hope that will fall in place, and we'll try and support in whatever way we can.
That is what I want to say. Some legislation should be brought in this country to have everything required for the trauma at one place. Maybe such a body is also required probably.
I agree. Thank you. Satish.
I think by trauma center we mean probably just organization of local resources to cater to trauma patients, because only that can be very low cost. If you think of a standalone trauma center, it will be an expensive proposition. But with the given resources, perhaps one can just organize so that we can give special treatment to a patient with multiple issues.
Absolutely, I think I entirely agree. There is no need to create a standalone new trauma centers, because that's not possible. That's we don't have resources to do that. But if you identify the hospitals or build on what you have, I think the key is build on what you have. If you identify the hospitals or the centers which are already present and empower them to focus on trauma care. Let them have their own capacity developed to rise to a level where they can competently treat trauma patients as level 1 trauma center. I think that is the goal. And I think if we equip them, if we empower them, if we designate them, and then give them some minor resources, which will not be more, to continue to operate at that level, I think that is what the purpose is.
As you know, I'm a great admirer of your work. I don't want to stand between you and the mementos and the audience and the lunch. But I believe, and we have done some work, and you're actually talking about my presentation in the afternoon, so you're very welcome to it. But my suggestion is that if you set the standards and allow people to declare that they subscribe to it, you will find that people will come in a wave who will want to claim that they are superior to the next person on the basis of subscribing to some standards that have been laid independently.
I agree. I mean, there's a merit in what you're saying. But I think in a country like ours, I think voluntary standards are not easy to be adhered. I think unless there is a structured way to offer the standards and implement the standard, I think that's the best way to go. But I take your point that there are more than one ways to achieve the same goal. Thank you.
So with no further questions, I think we will close this session. I think we have some comments regarding the lunch duration.
Okay. So
I think we'll probably leave the questions, if you don't mind, if it's a question regarding the session, to bilateral discussions that will occur over the next day and a half.
Actually, it's not a question, it's a kind of information. Good afternoon, everybody. I'm from Ministry of Health and Family Welfare and EAS. And I just wanted to inform there is a National Trauma Care program going on from Ministry of Health with a budget of 900 crores since 9th and 10th 5-year plan. And in the Dr. AIIMS Mishra has also informed everybody that we were developing 140 trauma care facilities in all over India, which has already been identified during 11th 5-year plan. And in this plan, 12th 5-year plan since 2017, we have a budget of creating more 85 facilities, in which we are designating government hospitals as level 1, level 2, level 3 trauma care facilities, and level 4 as basic ambulance care. I think everybody is not aware of this program because of
well, thank you. I think we all are aware. Most of us, particularly those who are in administration, know it that you are doing job for it, and quadrilateral triangle is going with NIHFW. Thank you very much for your input.
Okay, thank you so much, sir.
well, now we give our sincere thanks to all the speakers who have enlightened us with so much of information. Now it's time for appreciation of our speakers as well as our chairperson. So now I request Dr. Rajkumar to give the memento to Dr. Manjul Joshipura. Now I will request Dr. Muzaffar Ahmed, who is a member of Medical Council of India, to give memento to Dr. Rajkumar. I will also request Dr. Jiral to receive the certificate of appreciation from Dr. Muzaffar Ahmed. This is a token of love from our side. Okay, now I will hand over to Dr. Manish.
Yeah, good afternoon. This is just two announcements. The lunch is served at the first floor conference hall, which is little, maybe 50 meters away. Just go inside, or from the outside you can go, and it's above the auditorium. And the international participants, we have from 4 to 5 we have bilateral meetings with Indian delegation. So it is requested that between 4 and 5 you get the schedule. So you will meet all the delegations will meet the Indian delegation one by one. So you just be here at that time. So we break for lunch now. Thank you. Yeah. So we come back. We come back at 2:30. We come back at 2:30.